Now we will see the topic for fixed partial denture, that is Pontics. Pontics, according to Glossary of Prosthodontic Terms 8, is defined as that surface of the teeth which is replacing the missing tooth or the natural teeth, which is by an artificial crown, fixed partial denture part, or an implant by itself. So that is called as a Pontic, for where there was previously a missing natural, which was previously a natural teeth present. So that part is called the Pontics. Now in Pontics, what are we supposed to think about? We are supposed to think about what are the characteristics of Pontic. We have to find out the different designs of Pontic. What are the materials that we can give Pontics for? What are the Pontic fabrication? How is it done? The gingival architecture, preservation, the surgical modifications if required. Why will we require any surgical modification? So we will require any surgical modification if there is any Andrews ridge defects. So there can be pre-treatment assessments, tissue contacts and consideration, or most important among all this is somewhere which is missing here, post-insertion hygiene here. Post-insertion hygiene, which is important again to maintain the health of the Pontic as well as the health of the underlying soft tissues and the sides of the abutment teeth which is present. Coming to what are the requirements of a Pontic, there can be three requirements in all. It can be biological, it can be mechanical, or it can be aesthetical. Now the biological requirement that cleansable tissue surfaces should be there. They should have access to the abutment teeth, no pressure on the ridge. Mechanical, that it should be rigid because it should not break off. To resist the deformation, strong connectors, that is to prevent the fracture. There should be metal ceramic framework to resist the porcelain fracture. Aesthetic, it should look like that of a teeth. It should not look like something appears very artificial, appear to grow out of the edentulous ridge like our teeth grows out. Sufficient space for the porcelain should be there. Even that is a consideration of aesthetics, because if that is not there, the metal display will come out, and also the metal show color will also be on the surfaces of the fixed partial denture. Coming to the proper design. So for the proper design, what are the things that we need to classify and consider for a Pontic is we have to have cleanability, we have to have alveolar resorption and remodeling, and we need to even see the tooth contours. Now let's see one by one. Cleanability. Now a Pontic should be designed such that there can be a surface which is self-cleansable. So like it should be a C shape from down, the concave surface. It should not be convex where the food can go and trap inside. Alveolar resorption and remodeling. If there is more food trapped inside, bacterial ingrowth will take place, and then pocket formation, and then what will happen? The biological width will be reduced, and then further what will happen? The alveolar bone width will reduce, and hence there will be resorption of the alveolar bone. So hence this all process can be done if we have keeping the design of the Pontic little cleansable. Also tooth contours matter, because what happens is if we have a contour or the height of the contour is too much, the undercut area is much. So again there will be food lodgement in those particular area. More than that, food lodgement, the seating of the crown is going to be a problem and not be a fit crown seating. So we should not keep it over bulged. Exactly, we should be keeping it parallel, as we have already told. That is, an ideal taper should be 0 to 3 degree. Since 0 is not possible, 3 degrees is acceptable. Tapered on both the sides. Coming to the tissue contact, excessive contact should not be done again, because it will cause redness to that particular area. All the time we will have masticatory forces following on to that Pontic. So what will happen? The Pontic will in turn go and hit the ridge behind. So that ridge will get reddish and it will cause edema. So we are not supposed to do excessive contact. Small contact point should be there as less as possible. Like a T-shaped contact is a better option. We should have convex Pontic, very important. Not a concave Pontic. It should be down in C shape. Convex Pontic. Contact should be attached keratinized gingiva. Why the contact should be on attached keratinized gingiva? Because we know the gingiva is classified as keratinized and non-keratinized. And keratinized gingiva is that one kind of gingiva which can take up stresses pressure and forces. So that is the reason that we have keratinized gingiva even in our nostrils. We do have keratinized gingiva even in our mouth because it has to take up the stress of the food, mastication. So that is called the contact attached to keratinized gingiva is important so that it can take up the forces of the mastication. Scraping ridge, that is not advised at all these days. No pressure on the ridge is very important thing. It should be as less as contact with the ridge, and also the pressure should not be there. And inflammation free state, because once the pressure is putting on too much, that surface will turn red and will be totally wounded. Now a wound surface will not be good for the health of the gingiva and the periosteum and all the perioral structures around the tooth and the abutment teeth. So hence, that is the reason it should be inflammation-free state should be present where the contact is with the Pontic. Post-insertion hygiene, when I came up to, that is, after insertion of the hygiene, the brushing in those regions is very important. More than the brushing, food lodgement ought to happen beneath the Pontics. So you need to use floss, interproximal brushes, or pipe cleaners. Now those will remove the food which is there stuck in between after every meal of the food intake. So that the health of the Pontic in that particular region, in turn the health of the gingiva and the mucosa will be concerned and considered to be healthy if we are using a proper dental hygiene measures. Also, the mesial, distal and lingual embrasures should be kept wide open so that the food, it will have a spillway by itself. Spillway is any way created for the food to pass away. So there will be a spillway which is created by a mesial, distal, lingual embrasures which will be wide open. Coming to the non-appearances zone, the zone which is not appearing like posteriors, aesthetic is not of that concern, but then Pontic, the straight line between the retainers is important. It should be narrower than the natural teeth because natural teeth is a little wider. So when we are preparing the particular tooth of the abutment teeth and now the retainer will be on that, now the Pontic that we will give buccolingually, it should be narrower. Mesiodistal it can be bigger. So what will happen? We will have a bigger occlusal table for the mastication of the forces. But if we keep the teeth buccolingually more, so the forces will not get parallel to that of the long axis of the ridge, and hence detrimental forces can apply on the alveolar ridge, hence leading to resorption of the ridge. So we need to keep it as on the ridge, as small as possible. What are the requirements of a Pontic? So the requirements of a Pontic, that first thing, should replace the missing teeth and do its function. For example, mastication is its main function, solve the aesthetic thing, as well as it should provide comfort to the patient. Biologically, it should be acceptable. It should be able to maintain an oral hygiene. It is not that the floss is also not going inside, the interdental brushes are not going inside, or any pipe brushes are not going inside. Those kind of things should not happen. So oral hygiene maintenance is important again. That is the requirement, and preserve the underlying mucosa, because if we create a Pontic which is contacting the mucosa in a very hard fashion, that will create redness, wound in those particular area, and in turn will hamper the health of the mucosa. So that is the reason what we need to do is we have to preserve the underlying mucosa by keeping as less as contact with the Pontic as well as a convex kind of Pontic in the lower region. And one more important thing, that is, like for the Pontic, we have metal ceramic crowns when we are giving. Do not forget to put a layer of a ceramic over the metal surface which is going to come in contact with the mucosa, especially because metal is more of abrasion. It has got irregularities, where ceramic is smooth and it's more biocompatible. So hence that will not cause much of a defect to the ridge, whereas a metal can cause that. Pre-treatment assessments that are to be done, that is, the Pontic has to have to see that enough space is available. Generally what happens, a long-standing missing teeth will be taken up by the place of the side teeth as well as the supra-eruption. So the space for our Pontic which is supposed to come gets reduced. So we need to find out if there is proper Pontic space. Certain Pontics, like fish belly kind of Pontic, we'll come to different types of Pontic. The certain Pontics require more than 5 mm of space. So that is the reason designing of a Pontic and determination of what Pontic to be used is also important to do a space analysis. Residual ridge contour, again that is very important point. If the residual ridge contour is bigger, we cannot have a conical Pontic over there. We have to go for a ridge lap. So that is the reason in a posterior part of mandible or maxilla, the indicated Pontic is modified ridge lap. So these are the different ridge defects. Andrews different 1, 2 and 3 classified as 1 in less in width, 2 less in height and width, 3 less in width and height both. 1 width, 2 height, 3rd width and height both. Gingival architecture preservation. Now, preservation of the gingiva is also important. As we all know, gingiva is of two types. Biotype, that is thin biotype, and thick biotype. Now, when we come to thin biotype, those gingiva are specific gingiva we are not supposed to put any kind of pressure to that. The pressure point should be reduced as much as possible because it's already a thin biotype. It will tear off the gingiva in that particular region. Conditioning the extraction site is another important thing. At times, Pontic is also used for ridge preservation. Ovate kind of Pontic is generally used for preserving the ridge. Preparing the abutment teeth before extraction, interim fixed partial dentures can also be given. So we prepare the teeth before the extraction has happened. So immediately after extraction and the healing take place, the next very appointment we can fix the prosthesis. So what is an interim FPD or an interim fixed partial denture? So interim fixed partial denture is because of tissue blanching, to find out if there is any tissue blanching. High polished prosthesis, and after 1 month we are going to replace it. 1 to 1.5 mm, relief is given, and gingival levels are stable in the final restorations. Coming to preservation of the ridge, as I told you, orthodontic extrusion is correct. That is important. Orthodontic extrusion, extrude the teeth destined to be extracted, and apposition of the bone apically is also important for preserving the ridge. Now coming to the Pontic classification. How do we classify the Pontic and what are the different various designs of Pontic? So there are two basic kinds according to Rosenstiel book, that is mucosal contact and no mucosal contact. Those Pontic who contact the mucosa are called mucosal contact. Those Pontic who do not contact the mucosa are called non-mucosal contact. For example, a sanitary or a hygienic contact, they do not contact with the mucosa. Modified sanitary, there was some hygienic contact which was modified due to some shapes. Then there was ridge lab, modified ridge lab, ovate conical. We'll come one by one to all of them. Coming to the first one is a sanitary kind of no mucosal contact Pontic. So something which is related to hygiene. So how will we maintain the hygiene? So where can we use this? Where is the indication to use it? So the hygiene can be maintained when there is space between the ridge and the Pontic. So 2 to 3 mm space present between the Pontic and the ridge can easily let the toothbrushes, your interproximal brushes or our pipe brushes, your flosses to pass away and clean that particular area without lodgement of the food in that section. So mainly these Pontics can be used in the posterior regions, like for example molars posterior where they're not seen, because there will be space between the ridge and that of the Pontic. The aesthetics is gonna get hampered, questionable, so we cannot use it in the anterior regions, but in posterior it's a good choice of Pontic. So for example, we can see 3 mm of space is present between the Pontic and that of the ridge. One more important thing, the design of the Pontic should be convex, buccolingually as well as mesiodistally. This was the mistake in our ridge lab. We'll come to that. Modified sanitary Pontic, what they did in that is, see the sanitary Pontic. The distance was 3 mm, okay. The connector size was minimal and normal. Coming to modified sanitary Pontic, they increased the connector size. You can see the connector size is increased and this distance is decreased. Maybe the 7, replacing 7. We can use these kind of modified sanitary Pontic, also known as fish belly kind of Pontic, you can see. Or arc Pontic. It is also known as arc Pontic, fish belly kind of Pontic in many books, also called as modified sanitary Pontic standardly. Saddle or ridge lap. Saddle, as the word suggests, saddle is something that is the rider to sit on a horse. We use saddle, something in a shape of U like this. So a saddle or a ridge lap Pontic also has a shape like this. Now see, we could have seen from here, from buccally also it is touching, from lingually also it will be touching, and it is following a concave shape like this, and we have a Pontic. So this shape of the Pontic, so totally now the aesthetics is perfect, fine with this. The disadvantage of this kind of Pontic was its posterior surface. See this area, this is the area which was in contact with the ridge. The excess amount of contact of the area with the ridge was making the ridge unhealthy because more force was on the contact all the time. So the mucosal contact was not minimal as the requirement goes, but it was fetching the requirement of aesthetics. So what did the people do is they modified this. Since they modified, they only made a contact in T shape. Can we see this T-shaped contact? Only this particular part was in contact with the ridge. Buccal, it was covering the ridge, which we could see. Palatally, it was not. The area was no more concave, it was all convex. Hence, foot lodgement problem solved. Aesthetic problem solved. Most important, contact with the ridge problem was also solved. So this was considered as one of the best Pontics and is considered for the posterior region. This Pontic is considered to be one of the best Pontic, modified ridge lap Pontic. Coming to conical Pontic. Those ridges, those patients who have ridges like a knife edge, where the ridge is not as wide as one. So in those cases, giving a wide, big Pontic design will look bad. It will not look aesthetic. It will not, reciprocate the natural teeth which was present. So in those cases, conical Pontic is the treatment of choice. But again, conical Pontic, one good advantage is it is convex. Second good advantage, tissue contact is less. Bad one is no teeth is like this in a conical shape. It is at least in an oval shape. So this looks bad if you give it for the molars. Number one. Number two, the surface of this undercut which is present was more. So if you give it in the molars, foot lodgement will be more in this particular area. So conical Pontic was again discarded. Came the ovate Pontic. One of the best Pontic designs, but the difference in ovate Pontic and the original ridge lap Pontic was, ridge lap Pontic was concave in shape. Original ovate Pontic is convex in shape. We can appreciate this. See, ridge lap Pontic was convex in shape, concave in shape. An opposite C. Whereas an ovate Pontic is C, that is convex in shape. So hence foot lodgement was not a problem. Ovate Pontic exactly sits where the ridge is there. So again it was simulating exactly like the natural teeth. Ovate Pontic is used as a ridge preservation techniques. After the extraction is done, we give a temporary ovate Pontic so that the ridge is formed in the way of the Pontic design is there. Later on we can give, in weeks time we need to change the Pontic, modify the Pontic from the down and lessen the shape because the ridge is now healing, so it will comes up a little bit, but we want the shape to be like that, so we are keeping that Pontic in that particular shape, ovate Pontic, and preserving the ridge. We are not allowing the ridge to sink down or the buccal and the lingual cortical plates to break off and get down. No, we are not wanting that. We want a proper shape of the gingiva in the place from where teeth has been extracted. So ovate Pontic was a choice for even ridge preservation. Modified ovate Pontic, contact more labily than ovate Pontic, easier to clean, no need of surgical augmentation, push the labial gingival margin away to floss, was different modified ovate Pontic. Now what are the different Pontic materials that we can use? The Pontic materials can be aesthetic, it has to be biocompatible, it should have a good strength. The occlusal contact not on metal porcelain junction should be there. Glazed porcelain and gold if is used is the best. So the Pontic material, the minimal distance between the residual ridge and the occlusal table should be there, so that the force is not directed away from the center of rotation. Coming to the mechanical consideration, we have to have choice of material should be proper. Then the why mechanical failure will be there if improper choice of material is taking place. Poor framework design that we have designed. We have not given a proper Pontic design with a good amount of connector. In those cases, of course, there will be failure, poor tooth preparation or a poor occlusion per se. Or if we have not given a functional cusp bevel, even that case also the force will be more in that area and the Pontic will break off because the connection is a rigid connector. Metal ceramic Pontic, how much is the porcelain thickness? That is 1.2 to 1.3 mm, maximum 1.5. Metal comes around to be 0.3 to 0.5 mm. Rounded angles is important. Occlusal centric contact 1.5 mm away from the junction is important. Junction is the connector region. Now, this is an all ceramic Pontic, excellent biocompatibility, excellent aesthetics. And the only problem with this is if it is of color translucency, part has not been exactly simulated as that of the natural teeth. But yes, if we are using, that is in case if you are using a monoblock for the posteriors. But if you are using a nice zirconia, all ceramic, Uretria stabilized, all ceramic Pontics, in those cases we can get absolutely amazing aesthetics even with all ceramic. Resin veneered Pontics, we can see these are the resin veneered Pontics. We'll see that in different fiber in resin bonded elements. A new thing which has come over now is FRC, that is fiber reinforced composites, that is resin Pontic without a metal substructure. There is no metal substructure. What we do in that is, if there is, this is my tooth levels, let us take an example. If these are my two tooth, I will bond a strip of fiber from this to this, a nanofilled hybrid fiber, interpenetrating network fiber, like for example rebond, fix it with composite on both the ends, and here we will give an acrylic teeth attached to the fiber again. So the aesthetics part is solved. It is not, fiber reinforced composites are not for function but for aesthetic concern. So that is fiber reinforced composite without a metal substructure, matrix of impregnated glass or polymer fiber which I was speaking about. Excellent marginal adaptation and aesthetics. Poor, of course, poor in its function. Scalloped or trestle design. Now what is a scalloped or trestle design? Now connector is diminished in a faciolingual dimension. Now the connector which we are using, mesiodistal, it is swept wide. Faciolingually we have diminished its dimension. Bulk or rigidity in the connector area. We are giving bulk in the connector area, decreasing the size, but we are giving bulk in the connector area. Tissue contact, we are giving modified ridge lap. Those kind of is called, a new kind of design is called scalloped or trestle design of Pontic designs. So these are the different Pontic design, and based on that we need to select which Pontic design is suitable for our case, depending on the ridge, depending upon the aesthetics, depending upon the function, need of the patient, masticatory force that the patient is going to give, oral hygiene, how the patient maintains, is we are supposed to find out which Pontic design and carefully which material of Pontic are we supposed to use to replace the missing natural teeth. Thank you.